honored and excited to be talking about normal and abnormal post-bariatric surgical anatomy. Here are my disclosures. My goals for the talk are to help you understand the anatomy and normal endoscopic findings of bariatric surgeries, and to review some of the common abnormal endoscopic findings in these bariatric surgeries and their management. We're going to be going over the 3 most common bariatric surgeries being performed worldwide, including gastric band, Roux-en-Y Gastric Bypass, and sleeve gastrectomy. Let's start with gastric band. The surgery involves placement of a silicone band over the cardia to create a 15 cc pouch. This band is also connected to an infusion port, which remains in the subcutaneous tissue and can be accessed for fluid injection or removal. Here are the normal endoscopic findings of gastric band. Once you pass the GE junction, you can see a small pouch at the proximal stomach. Additionally, you can see an extrinsic compression from the band up, which sits outside the gastric lumen. Once you go into the rest of the stomach and do a full retroflexion, you can also see that band. It's important to pay attention to the GE junction and additionally to fully insufflate to look for any band erosion. Here are some of the abnormal findings of gastric band. These include reflux esophagitis, food residue in the esophagus, which may represent pseudoachalasia, and band erosion. Reflux esophagitis may be seen in up to half of the patients with gastric band. This may occur because of excessive filling of the band. Treatment is PPI, and you should also ask your bariatric surgeon colleague to possibly deflate the band. What about pseudoachalasia? This occurs in about 10% of the patients with gastric band, and it's due to the band being too tight. So the treatment is to deflate the band and then re-stroke the patient in about 6 weeks or so. Another possible finding is band erosion. Patients may present with non-specific GI symptoms such as reflux, nausea, and vomiting. In this case, a patient might actually present with abdominal wall cellulitis. When I did an endoscopy, I saw both a band and tube protruding into the gastric lumen. If the buccal is visible, you can remove the band endoscopically. For example, in this case, I passed a stiff wire around the tube and band, fed that wire into the mechanical lithotripter prior to cutting and removing them endoscopically. For this case, a surgical colleague was also in the room, removing the port percutaneously. Moving on to Roux-en-Y Gastric Bypass. During the surgery, the stomach is divided into a 20 to 30 cc pouch, and the remnant stomach is excluded. Here are the more common abnormal findings of Roux-en-Y gastric bypass, including marginal ulceration, gastric fistula, and laminated gastrectomy anastomosis. Marginal ulceration occurs in up to 16% of the patients. The most common location of the marginal ulcers on the posterior aspect of the jejunal side of the gastrectomy anastomosis. Patients may be asymptomatic or they may have symptoms. For example, this patient of mine presented with GJA stenosis. When I traversed the stenosis, I saw a hemicircumferential ulcer, which was treated successfully with open capsule PPI and Carafate. For recalcitrant marginal ulcer, you may consider oversewing endoscopically. However, if the ulcers are more spread out, like this one on the right, surgical revision should be considered. Another abnormal finding of Roux-en-Y gastric bypass is a gastric fistula. This refers to an abnormal connection between the pouch and the remnant septum. The most common location of a GG fistula is on the left side of the pouch, as shown in the left picture here. If the fistula is smaller than 1 centimeter, you can consider closing it endoscopically using a modified endoscopic submucosal dissection followed by suturing, which has a success rate of about 60%. Another common finding of Roux-en-Y gastric bypass is a dilated outlet or dilated gastroduodenal anastomosis. Patients may present with weight regain or dumping syndrome. Treatment includes pharmacotherapy or transoral outlet reduction, which may be performed using argon plasma coagulation, suturing tour, or placation tour. In general, the procedure is associated with about 10% total weight loss up to 5 years. The surgery involves resecting and removing the fundus and 80% of the greater curvature. This leaves the patient with a long tubular 100 cc sleeve along the lesser curvature. Currently, this is the most common bariatric surgery being performed in the US and worldwide, except for patients with obesity and concomitant diabetes or GERD, who should undergo Roux-en-Y gastric bypass. Here's what we see on an endoscopy of patients with sleeve gastrectomy. You want to pay attention to the GE junction. On the right upper corner, you see this is the sleeve body, and you can tell this is a sleeve gastrectomy anatomy because of the staple line along the greater curvature. In some cases, you might be able to do a full retroflexion to look at the GE junction, and you want to pay attention to the hiatal hernia loop grade. Additionally, in the antrum, this is where you want to look for any bile reflux. Here are the more common abnormal findings of sleeve gastrectomy, including esophagitis, Barrett's esophagus, sleeve leak, which will be covered in more details in Dr. Demore's talk later today, and sleeve stenosis. De novo GERD and Barrett's esophagus may be seen in up to 10% of the patients following sleeve gastrectomy. Therefore, a lot of surgeons actually put patients on PPI immediately after the surgery. However, if their acid reflux symptoms persist, you may consider treating it endoscopically with ARMS, which stands for an anti-reflux mucosectomy procedure, STRATA, or TIF, which is an endoscopic fundoplication, although this is more limited due to difficulty retroflexing the device in a sleeve gastrectomy anatomy. Ultimately, some patients may need a conversion to Roux-en-Y gastric bypass. Another common finding is the sleeve stenosis, which may occur in up to 4%. Patients may present acutely or more commonly chronically. The most common site is at the enzosora. When you pass the scope through this area, you want to pay attention to make sure you don't have to do more clockwise rotation or big knock up, which may represent a stenosis. If patients present within the first 6 weeks after the surgery, you want to dilate this with a CRE balloon. However, for chronic sleeve stenosis, we want to consider using pneumatic balloon dilation. Here's our algorithm of how to treat a sleeve stenosis endoscopically. As you can see, we start with a 30 millimeter pneumatic balloon and gradually go up on the pressure up to the maximum pressure of 20 psi. After that, we start going up on the size to 30 millimeter and finally 40 millimeter pneumatic balloon. In conclusion, it is important to understand the anatomy of common bariatric surgeries. Several complications of these bariatric surgeries can be diagnosed and treated endoscopically. And last but not least, management of post-bariatric surgical patients should be done in a multidisciplinary approach with close collaboration with our bariatric surgical colleagues. Thank you very much, and I'm happy to take any questions.